So thank you, everyone. We have a nice panel session with a wonderful round of panelists here. So I have here on my left Assumpta Ricard, who is the director of the Catalan healthcare system. And then we have Madalena Hilario and Buenaventura Ruiz, that you know already. So I wanted to start this panel by asking Assumpta, what are the regional health plans to bring forward AMR innovation in your region, in your institution?
Thank you. Can you hear me, or I have to put this one? Yes? Is it okay like this? No? So, maybe I'd have to put it... it's, well, not very old, but... pardon? No, it's open. It's green. It's open. That's all we can have. It's green. Yes? Is it? Okay, so great. Well, first in Catalonia we are fortunate because we have healthcare professionals not only delivering care, but they are really good and they are very strong in innovation mindset. So in fact, from the administration point of view, it's quite overwhelming because they are producing and they have a lot of ideas. And really the great challenge is how we introduce this into our health system, how we make that all this innovation gets the patient, reaches the patient. So in that sense, we are quite proud because we are making real progress in bringing all the key players together, key players that can channel all this innovation to the patient. And so this is our Agency of Quality and Assessment, our Health Department Strategy of Innovation, the ICT Foundation, and of course the BioCat as a key driver for innovation ecosystem. So we really are together. In fact, I would say that we are friends, and that's very important because we can control all the innovation and try to get the system. So from the point of view of the Catalan Health Service, our instruments are governance, contracting, and of course incentives. And on this sense, first on governance, we are investing quite a lot of money on having a structure with 3 plans. First one is BINCAT, with its unified surveillance systems on infection related to the system. Then the PRAN, which is the Catalan Antimicrobial Prevention and Optimization Program, and then the PRAN, which is the program for antimicrobial resistance. This last one is not only for Catalonia, but is for the whole system. But so this is about governance, but about contracting and incentives. I would say that the most distinctive contribution that Catalan Health Service lies on how we use our purchasing and financing role. On this sense, even it's timid and we would like it to be bigger and bigger. We have a system of value-based contracting. So the Catalan Health Service receives all the money from the government. It's about 14 billion euros for healthcare. So Catalan Health Service transfers this money to the providers, and they do the job. They provide the care. So we do not prescribe. We do not buy equipment. So our instruments is the value-based contracting. So in the contract with our providers, 5% of this budget is at risk. So it's associated, is linked to the achievement of objectives. And in fact, talking specifically about antimicrobial resistance and the issue that we are talking today is that, for example, we have one of these objectives is mandatory surveillance. So it's obliged, of course, because if not, you will not receive this part of your contract. The second one is the program, the antimicrobial stewardship, and it means that these objectives are linked to antibiotic consumption, to resistant patterns, and one very important, which is targeted prescribing improvements. And then the third part of these objectives is infection prevention and patient safety. It means that we control and we pay, or not pay, where they receive this 5% or not, depending on the infection-related, hospital infections related with the healthcare, not only hospital, but also in primary care, or surgical site infections. So this is a timid part of our value-based contracting, but it's 5% of a big amount of money. So these are the main governance, contracting, and incentives.
Okay, thank you. Yeah, I wanted to know as well, in this current geopolitical context and also the different challenges when it comes to definition of health and all the, the societal role of health and the so what how is your institution adapting to this ever-changing environment? How are you? I don't know, with population services or specific patient groups?
I don't know if I understand. Could you please repeat the question?
So what is the, how are you adapting to the real future challenges of health from your institution?
Well, that's really, in fact, our system is, we adopt because our planification and, for example, our instrument is healthcare plans. Mm-hmm. And so through healthcare plans, politicians define which direction we take. And then the Catalan Health Service, which is the arm or operational arm of the health department, translates it into operational actions. So, for example, I reviewed our healthcare plans. Mm-hmm. In the last 3 ones, it means 12 years, and in the 3 of them for 12 years, antimicrobial antibiotics use and antimicrobial resistances, it's specifically in these plans. So I think that the most important thing is that always see that is not a clinical issue, but the most highest system level commitment. So starting with the healthcare plans, and then through contracting, and then through our providers do things, they perform the assistance. So it comes from up bottom, of course. So the strategy is directed by the health plans.
Do you also interact with other players like cities, patient groups, or?
Well, all our plans nowadays is unbelievably. We cannot all our plans or our planification. We have patients inside. All our expert groups always. Sometimes from the beginning, and sometimes with focus group, or sometimes after we have the plan, then we consult with them. But they are present in our planification. I think we cannot imagine any planification nowadays without the citizens in it. In fact, our healthcare department has a school of health that is addressed to citizens to improve the capacity to influence the system. Mm-hmm. Because what happens when we count with the citizens, they don't have the power or the way, or not. It's difficult for them to arrive to our strategy. So even though the health department takes care that they can improve their skills to present proposals to the system.
Is there any other thing from your institution that you want to highlight? Any lessons learned?
Well, maybe they can. It's all the time for me. So no, okay.
I think it's okay.
So maybe later.
Okay. Yeah. So my question for Madalena. So I know that you are not only working in the AMR field, you're also working in other public health areas. I would like to know that. What challenges are common between AMR and non-communicable diseases, and how these public health actors should work together?
This is a really interesting questions, because AMR shares with the chronic diseases patients the risk So most of these patients have multimorbidity. They are affected by conditions that bring them inside and outside of the hospital many times. Like if you think of cancer patients, of diabetic patients, and these patients are exposed to procedures that are at risk of contamination. So probably the good way to go hand in hand would be trying to push antimicrobial resistance principles into the diagnostic therapeutic pathways for these patients. And if you think about non-communicable diseases in multimorbidity patients, in these cases you have polypharmacy. Polypharmacy itself can be a risk for drug-to-drug interactions, so there is a need to push for medication revision, the prescribing, and this could be helped if we would strengthen awareness of appropriate antibiotic prescription. So there are several points where they touch each other, and I think if they could at least identify some synergic objectives, they could reciprocally strengthen the improvement of overall health outcomes and sustainability even. Yeah.
Thank you, Madalena. I also wanted to ask you so about your contribution to the National Action Plan in Italy based on your work in RaDAR. And I know that from the European perspective, for example, there's been some advances when it comes to AMR plans to apply joint procurement and stockpiling of antimicrobials, also pre-commercial procurement for diagnostics. And also in Italy, you developed recently an incentive program for new antibiotics. So, yeah, what do you think? How do your work in RaDAR aligns with the strategy in Italy?
It's very well aligned because I think that the investment in new antimicrobial drugs is very important. We need it, but it's not the solution. It's one part of a solution that is more broadly represented by what we managed to integrate in RaDAR. We have a new plan to tackle antimicrobial resistance, the PNCAR in Italy, and what it looks for is reducing, strengthening interoperability and reducing silos between data, improving appropriateness of prescription of antibiotics, improving surveillance, and strengthening stewardship. So these elements were all included into the solution we have been implementing in RaDAR. Even if we didn't manage to achieve full deployment of all the potential of the solutions we purchased, there is a very broad opportunity to continue exploitation of RaDAR solutions to implement the national PNCAR in Italy. But there is one point that emerged during implementation in our settings, that is the human resources. So there is we need more nurses and more infectivologists and more microbiologists to really implement in the community, because the hospital are understaffed, but the implementation of the antimicrobial resistance plans in the community is even more challenging. So we will need to invest also in human resources, and there are gaps between Italian regions that should be addressed if we seriously want to achieve these objectives.
Okay. Thank you, Madalena. Very nice. And then we have Bonaventura. I would like to ask you about, so you have shown your solution in this project about the combination of rapid diagnostics and whole genome sequencing. How do you see this being feasible in the near future, and then the benefits and the barriers for this implementation?
Well, okay. I think now we are all convinced that AMR is really a problem to tackle. It's something urgent, and it is a thing that must be tackled by several actors. One is the health professionals, although in the laboratory or in the hospitals, and also by the in vitro diagnostics companies, also with IT companies, and well, it's a problem of different actors. There is also a problem too with the managers, and also at the level of a systemic management of the health system, because these solutions need resources and needs money. Okay. In our case, we joined the RaDAR in 2024, but there was previously a commitment and also a background in trying to afford or to apply to tackle this problem at Hospital del Mar in Laboratorio de Referencia Catalunya. So the PPI RaDAR acts as a catalyst to put or to translate this preparation, this background to reality. We have running this pilot during 8 months, and the results are quite promising. I don't know if spectacular results, but are quite promising, just to let know that there is a good basis to work with in the future. At what point are we in Hospital del Mar? Well, as Dr. Ricard said, the Catalan health system contracts services to the hospitals, and the hospitals have to receive money for these services. There is no special program to the vigilance or to tackle the problem of AMR. So it's something new, something that costs money, and I think the hospital at that time it's not easy to invest money in something that is new. So they are waiting, for example, I know Hospital del Mar and other hospitals that are really not in a good circumstances in the economic point of view. Always the healthcare is always very demanding of money, and new actions take times to be adopted in the hospital. So I think it's a very nice step and a productive step, but it needs time for a hospital, in this case for Hospital del Mar, to be adopted in the routine system. But the results are quite interesting, and it's a good basis to work with in the future. I don't know if I've answered your.
I would like to.
Sure.
I would like to mention part of what you said, because you said, well, Catalan Health Service is not investing specifically on antimicrobial resistance. They're struggling against antimicrobial resistances, but what costs the most is not to do anything. So Catalan Health Service contract services for you to do the job. So if you do it cheaper, the difference is for you. So the cost of infections due to multi-resistant infections are so huge at hospitals. In fact, the difference is of patients with or without nosocomial infections with non-susceptible, it's 33%, and the length of stay it's 27%, and mortality is 61%. So since we pay for performance, the activity, and you introduce these systems and you save money, you have more money to invest in yourself. Yeah. So I think this is a key point, that we don't expect from the system to put more money, but to respect the money and do it better, because the difference is for the provider. So I think that we have a large improvement area here. So.
I think there is.
Sorry.
There is always no. But there is always an initial. It's like an enzymatic reaction. Eh? You always need a initial burst, seen as the part of the hospital and the managing team in the hospital. It's not really a savings just in the moment zero. You need the time to do the initial investment, and that's why it's really a barrier. Yeah. I think.
In fact, the problem is that you save money, but maybe you save money next year, 2 years. But to initiate it, you need to push. You need this money. That's true. So, but it's a matter of efficacy, and this to try to avoid these infections is save money. But yes, and the other problem, especially in Catalonia, I don't know in other countries, but we don't really have a system with a good public-private collaboration. So we are very fond of public health, and of course I am, and I think all we share this. But at the end, if we are not confident, we don't establish a good relationship with public-private collaboration, this is not possible, because this money you need to invest and to save money in the future. Sometimes it's the industry who has the money to put it on it. So maybe in our system, the public-private collaboration is not enough to adopt innovation, I think.
No, you can get it. So I had just one last question about I think it's the pharmacology unit of the Hospital del Mar, where you do like personalized AMR treatment. I don't know if you can share a little bit of this. Of its innovative strategy in your hospital?
I guess you visit our laboratory,
yes.
and saw this unit and get quite impressed. No, it's just to mention, it's not directly directed with antimicrobial resistance, but it's indirectly. This is in Laboratorio de Referencia Catalunya in collaboration with Hospital del Mar, and there is since I think 7, 8, 10 years ago, they were established a unit that does pharmacokinetics and pharmacodynamics of antibiotics and other molecules, just to test in vitro what are the efficacy of the antibiotics and to optimize doses in the patients. And they do this with a in vitro model that is called the hollow fiber. If you type in Google hollow fiber, there is a model that it was created 10 or 15 years ago, and it works very well in order to mimic in vitro and in very controlled conditions of biosecurity what it happens in the patient. And then you can adjust and monitor and optimize very well the doses of the antibiotics. It's quite particular.
Okay, very, very interesting, thank you. I don't know if we have time for more questions. Yeah. Okay, so we have some more general questions. Yeah, do you think that the solutions shown in this project are economically sustainable without EU funding support?
Well, I think I answer. What is not sustainable is not to do something, because it costs a lot. So we have to think of the price of not doing, definitely.
Yeah, I agree. I think that we need to collect more data to show to politicians that the money spent in innovative solutions is worthy. So I know for a fact that we are already with this experimental approach reducing the days, the length of stay. So that then you can do the count, because if you have just counting the reduction of the length of stay, that is a case, that makes a case for sustainability. But then there are a number of direct, indirect cost, social cost, impact, and other things that you can pile up in the calculation that deserve a real cost study that we could do starting on the ground of the platform that we have been developing lately. So this is something that has to do. I would do an avoided cost study, very simply.
I would like to add a new question, that is that, well, in fact, illnesses doesn't work from 9 to 5. Illnesses are always there in a 24/7 day basis. And our healthcare systems are mainly based, and yet now working in this shift. Reasonably puts the necessity, for example, for the microbiology 24/7 in every hospital or every tertiary hospital here in the country, and of course everywhere. And this, of course, it translates in more amount of economic burden in the hospitals. But it's something that we have advanced to solve in the near future. Today, what the questions that it has to be a laboratory of analysis, biochemistry, and hematology 24/7, and I think we are demonstrating that it's the necessity in the microbiology also works like that, and also the other part of the lab, the clinicians, in order the results to be actionable. With actions, there have to be someone at the other end of the phone ready to make a decision on isolation or something like that. So it's complicated. It's not easy to translate these pilots to the reality, because they have associated a lot of cost and changes and tensions in the organization of the hospital. So it's a challenge for all of us.
But I think that Catalonia is very good shape, because what you are saying, that you are set for innovation, is very important. This means that you have, at least compared to other healthcare system, the use, the habit, the flexibility to adapt to the integration of a new solution, because otherwise there is a resistance to change that is especially due to the healthcare professionals, the nurses, that if they are not used to work in innovative environments, could make impossible the implementation.
Thank you for your words. Yes, we really are in the ecosystem that is open to change, and I think it's quite flexible. Anyway, the great challenge is how all this innovation is introduced in our public health systems, and in fact, nowadays is the main problem. We have a lot of solutions, but it's difficult for us to find how we introduce it, how we adopt it into our system. That's the main challenge.
May I ask you a question?
Yeah, sure.
If I may. So you mentioned performances. So do you acknowledge the involvement of healthcare professionals in innovation activities in the performances of the healthcare system? Do you acknowledge, so do you value in the performances the involvement in innovation?
Absolutely. We have several initiatives. In fact, one is BioCard, and we have here also some representatives that we are making calls. We want to go from a reactive system, which people innovate, and they do a lot of things, and then we don't know where we are, and even some solutions, maybe we don't need them. So I always say that we have a lot of people with solutions that they are looking for problems, no? So we have a lot of, so we want to go from this reactive to a structured adoption of innovation, and how we do it through this putting all the players together and going for calls. For calls where, from different points of view, Aquas, the Salud, Health Department, we all accompany all these innovators to get to go to a good end. So I think from reactive system to proactive address to introduce innovation.
I think this is a very important lesson for your colleagues in the other countries.
Oh, thank you. So we are just learning.
One last question I have is about, do you believe that Europe is creating the appropriate market conditions for the adoption of AMR innovation?
Say it again.
Do you believe that Europe is creating the appropriate market conditions for the adoption of AMR innovation? Or still far away?
No, we are not far away. I think we are in the middle. We are in the middle of the transformation, and there is a lot still to do, especially in the administrative part, because it's not. Whereas if you make a change, professionals in the healthcare system, in the university, they self-manage, adopt, study, and implement. In the administration, it's very straightforward, top-down, so you need to brainwash the director general to convince him to embrace innovation. Because I think administrative compartments is a silos, then they think that innovation is not related to them. It's something that concerns other people, so they are not involved. So I think this is something we should explain them, that if the society needs innovation, they are part of the players of the innovation, and it involves them. It's a responsibility they need to take, and they should take the responsibility to make an effort and implement innovative solutions. It's too easy to say, oh, I've never done it, I cannot do it, and someone else's responsibility. It's also the responsibility of the administration.
Just my part, just to say that I'm quite confident with companies of in vitro diagnostic sector. They are, if in Europe, in Europe, they make the conditions that they work and think and develop new kits and new strategies. They have a strong, the big companies and also the small and medium enterprises. They have the talent and also the will to advance in this project. So make them easy to work.
Well, I really don't know the market. I would say that Europe is making efforts, and RaDAR is an example of how you can put together buyers in different countries, and it's RaDAR has demonstrated that it's possible to do it together. But it's really, really extremely complex. In fact, I wonder how RaDAR has been possible, because when we try it in our region, it's so difficult, and we have the same system and the same payment and financing models, and even in that, it's so difficult to put them together. So this is a real example. It's possible, and I hope that RaDAR leave us not only the results you have presented, but also a methodology that can be used in the future to promote these initiatives, because if not, RaDAR would have not been enough. So I hope so.
Thank you. I think this is a very optimistic way of finishing this roundtable. Thank you so much for being here.
Thank you very much.
Thank you.